right, so thank you so much, Dr. Coburn, for being here today. I will hand it over to you.
Okay, great. Thank you. Thanks for inviting me to talk about this. As Erin said, I'm one of the surgical oncologists. I work at the Adet Cancer Center, and I do hepatobiliary surgery and gastric surgery. So, a bit of an eclectic practice. Erin asked me to talk about a Whipple, because that's where a lot of questions come from. So, we said how long I've been on staff. I'm old. I use whiteboards. So hopefully you guys can see all of this. I'm going to draw really big, but Erin asked me to talk about surgery. And so I want to talk about the anatomy and the surgery and kind of what happens afterwards, which I think answers a lot of questions about why I'm not a candidate for surgery or what happens after surgery. So we kind of have to set and talk about what the surgery is so that we can answer those questions. So if you guys have questions as we go, feel free to jump in. I'll try to monitor for hands going up. But she asked me to talk about a Whipple and a distal, and then is surgery right for me? Since this is being recorded, I'm going to assume that other people other than the ones who are online are going to watch it at some point in the future. And then what happens after surgery? So to answer all of these questions, we have to think about anatomy. So I'm going to start to draw, and if you guys can't see it, let me know, and I will pull the laptop in a little bit. The pancreas sits at the back of the abdomen. It kind of looks like that. That looks a little washed out to me. I don't know about you guys. I'm going to pull this screen down for 1 sec.
I'm so sorry, Dr. Coburn, it got muted somehow. There we go.
Okay, does that look better? That looks less washed out to me. Yeah. Okay, so pancreas sits at the back of the abdomen. The pancreas does 2 really important things. It makes insulin, which manages your blood sugar, and it makes enzymes which help dissolve your dinner. So if you have a steak dinner tonight, the enzymes from the pancreas help to dissolve that. That's all it does. Otherwise, it's just nothing but trouble, right? So when you eat, food goes down your esophagus, and then it goes into your stomach. And then there's this piece of small bowel that swoops around the pancreas, and this is called the duodenum. So this is technically part of the small bowel, but it's called the duodenum. And the pancreas makes its enzymes, and the enzymes come down the duct, and they go into the small bowel to help you absorb your food. That also connects up to the bile duct. So the liver is up here, little gallbladders off to the side, and then the bile duct connects in here. So bile comes down from the liver and goes into the small bowel as well. So between the bile and the pancreatic enzymes, you absorb your steak. If you have a blockage here, so if the cancer sits right here in this zone, sometimes it will push on the bile duct, and that's how you get this blockage where you turn bright yellow. Because the liver gets blocked and the bilirubin builds up and you turn bright yellow and you're jaundiced. And that's how a lot of people end up going into the emergency department or coming to the attention of their family physician because the cancer sits right here. That's this side over here on my right-hand side is where we're going to do a Whipple. If the cancer sits out here in the tail, so this is the head and this is the tail, these cancers can get much bigger before they cause any symptoms. And so when people say that it's better to have a cancer here rather than over on the left-hand side, this is your right, this is your left, that's because these lesions over here in the tail can get much bigger before they're picked up. So for right now, let's talk about the ones that are on the right-hand side or in the head of the pancreas. And those are going to be the ones that surgeons think about doing a Whipple for. So when we're thinking about doing a Whipple, we have to take out the tumor, and we also take out the lymph nodes that are in the area. The anatomy in this area is really complex, and the blood supply is the same. So you can't pick these things apart. So you can't pick and choose and take out the duodenum but leave the pancreas, or take the pancreas and leave the bile duct. All of it has to come out. So you can't go through here and kind of pick and choose what you take out. It all comes out. So you divide the pancreas in half. You take out this sweep of small bowel, the duodenum. Some people take a a little bit of stomach, like 5 to 10% of the stomach. Some people leave all of the stomach and just take the duodenum. Not a big difference there, but lots of people talk about it. Then you take part of the bile duct, you take the gallbladder. So you're gonna take all of this out. This whole zone, all of that is gonna go to pathology. So the pathologists are going to look at all of that under the microscope. They're going to look at the tumor. They're going to look at the blood vessels. They're going to look at the lymph nodes. And then the pathologists are going to give you what you need to know kind of later on in terms of making decisions about what happens in the chemotherapy and the duration of the chemotherapy and really the risk of recurrence. The answer to all those questions comes from the pathology specimen. So a lot of times in clinic, people want to know, okay, what's the chances it's going to come back? I don't know because I don't know what the lymph nodes show. So if you have a situation where there's no cancer in the lymph nodes, that's obviously a much better situation. We're much more able to cure that with surgery and chemotherapy than if you have a situation where the pathologist looks at 20 lymph nodes and 10 of them have cancer in them. That's much worse. That's much more likely to come back. None of it's a given, but those are the ones we worry about. So all the questions about is it going to come back or not, that gets answered a lot by the pathologist, and this usually takes around, I would say 2, but often edging up to 3 weeks to come back. And while you want to know this answer, whether it comes back at 1 week, 2 weeks, or 3 weeks, it doesn't actually change anything because you're not going to start on chemotherapy at 2 weeks anyhow, right? Because then we're going to talk about the after surgery. So this is taking everything out. About halfway through the operation, you have an esophagus, you have a stomach which you have divided, you have your liver which you have divided, and you have your pancreas which you have divided because you took all of this out. You took out this half of the pancreas, you took out a bit of the stomach, you took out all that loop of small bowel, and you divided the bile duct. So that's what you have about halfway through the surgery. So you take this loop of small bowel right here, that's the world's worst star, and you actually hook it up to the pancreas. And then we hook it up to the bile duct, and then we swing it over and we hook it up to the stomach. So everything is there, the food all goes through, comes down the small bowel, goes into the colon, comes out as poo, slightly rearranged. And this rearrangement is what causes some of these issues after surgery. So if you come and talk to us at the Odette, what I'll tell you is, this is a big operation. This is nothing that we enter into lightly, and there's a lot of conversations about it. So this is Whipple. This is the same operation that's been performed for about the past 100 years. There's not a lot of modifications on this, but it is what it is. Everybody's in the ICU for the first night, at least. The ICU is nice because the nurses in the ICU have 2 patients or 3 patients, as opposed to the nurses on the ward who have 6 to 8 patients overnight. So that's why we put everybody in the ICU overnight, so you get a little bit more extra attention. Hopefully be out of the ICU the first day, minimal 5 days in the hospital. It's a big operation to recover from, and you change the way you're eating slightly. So minimal, we say 5 days in the hospital. Average is around 7. 5 days. We've had a few people. One person was training for marathons, like super duper healthy. They left at 4 days, but other than that, most people leave around 5 to 7 days. Now, we talked about this terrible pancreas, which helps dissolve things. Think of it like Drano. So it helps dissolve your steak dinner when you eat it. And then when we put it back together in the operating room, the first thing the pancreas does is it tries to dissolve this thing that we just created. So this is the area we worry most about. And if you think about the issues after surgery or the adverse events or the problems that happen after surgery, most of the problems after surgery happen because of the pancreas. So this is kind of what separates this operation from a colon surgery, where you also put bowel back together. you have these additional enzymes. So the chance of having a problem here is about 20 to 40%. And I take this data from the world literature. It depends on what you consider an issue. It depends on how carefully you look through your cases. And it depends on how you manage your patients. You know, if you get a CT scan on everybody after the surgery, you're going to find a lot of fluid collections. And by strict definitions, any little fluid collection here is kind of off track. And so you would have to count that. If you don't do a lot of CT scans, you may not see this as much. But so a lot of these are not clinically important. They're not going to change what happens to you. But they are things that, you know, the team would talk about after the surgery, like, oh, you have a little fluid collection here. So if you have a little tiny fluid collection here, the team is probably just going to watch it and leave it alone. If you have a bigger, if you do a CT scan and you have a bigger fluid collection, nobody's going to be happy about that. And they might ask the radiologist to put a drain into it. If it's particularly large, it may push up on the stomach, and that might cause your stomach to not empty after surgery. That's one of the most common reasons that people stay in the hospital a little bit longer. Occasionally, it can cause an abscess or a big infection here, and occasionally we have to go back to the operating room. That doesn't happen often. It's less than 5% of the time. But if that happens, that is really quite important because that can make you really very sick, and that usually gets you back up into the ICU. The chance of having a problem with the bile duct is about 5%. The chance of having a problem on the stomach is less than 5%. Then we worry about everything every other surgeon in the world worries about, like a wound infection or a urinary tract infection or blood clots in the legs or stress on your heart, like a heart attack, or stress on your lungs, like a pneumonia. So when you add up 5% here and 5% there and 10% here, the chance of having something happen around the time of surgery is about 50%. So the chance of having something happen around the time of surgery is about 50%. That becomes really important because that keeps you in the hospital longer. It slows down eating and gaining weight, and then it has cascade effects slowing down chemotherapy. So that's one of the reasons that we make decisions about offering surgery to people or offering chemotherapy up front, is this issue. Because we know if you get into this adverse event category, getting back onto chemotherapy is more challenging. It is a big surgery. If you look across any large institution or any provincial database or any national database, the chance of death around the time of surgery is about 1 to 2%. So, that's high. So if you think about something like a hernia surgery or gallbladder surgery or breast surgery, you know, they measure their mortality rate, you know, kind of like 1 in 4,000, 1 in 5,000, 1 in the thousands. And so this is a big surgery. So I'm going to stop and pause here and see if anybody has any questions on this part of it.
There are a couple questions that came through the chat.
I didn't see the chat.
Oh, no worries. No, sorry, I didn't want to. Nadine said, will we also talk about surgery when the tumor is in the middle of the pancreas? I know that at least 2 of us in the group have our tumor in the center. I have additional precancerous cysts on the head and the tail. So I was told if I could have surgery, I'm stage 4, I would need to have my entire pancreas removed.
Yeah. Okay. So if it sits here in the center, it kind of depends. That's really the best thing you can say. It depends. So if it sits smack dab in the center, a lot of times what we'll do is a distal. So we'll talk about a distal now. So a distal is a much smaller operation. So you take out the tail, but you leave all this part about the bowel and the bile duct, you leave that alone. So you don't have to worry about putting everything back together. So because you're not putting things back together so much, you're not as worried about this area. So and a distal pancreatectomy, you take out this area. So I drew my spot right here, which is really nice because it's far out to the left. So it's easy to remove. The blood vessels to the spleen are right here. So usually the spleen has to come out as well because the blood vessels to the spleen run parallel and right behind the tail of the pancreas. So if you do a distal pancreatectomy, you take out all of this. Now, interestingly, the chance of having this fluid collection is about the same and perhaps even a little bit higher in the distal pancreatectomy. But because it's not hooked up to a loop of bowel, it doesn't end up causing as many problems and making people quite as sick if there is a fluid collection. So the risk of having a fluid collection is a bit higher with the distals, but the chance that it makes you super sick is a lot lower, which is good. Roland's got a question. Whoop, and he's muted. Glad it's not just him. No,
You're on mute.
There, can you hear me now?
yes, yeah.
Yeah, okay. My question is about when you have a mass in the head of the pancreas, but the tail is atrophied, like my tail has kind of shriveled a little bit. How much of the tail do you need to be able to do that surgery?
So that is an excellent question. I'm going to combine that with the central question. So
Okay.
so I drew it here to make my life easier as a surgeon. If it's here, you'd still do a distal. If it's here, you do a really aggressive distal. The issue is where it starts to come really close to this bile duct. So you don't want to be just skimming right off the edge of the cancer because you worry about leaving cancer cells behind. So if you had something that was more sitting here, you would probably just do an extended Whipple and you'd probably just push your margin over that way a little bit. So I think for the central lesions, the answer is it depends. And certainly if we could do a distal, the chance of having a bad problem after surgery with a distal is lower than the chance of having a bad problem with a Whipple. So if we can do a distal based on the anatomy, we're always going to pick that. There are certain indications for doing a central pancreatectomy. Those usually are for neuroendocrine tumors because you're not as worried about spread of the cancer. So usually the centrals are for neuroendocrine tumors and not pancreas adenocarcinoma. So there are certain indications for it, but it's limited. There are certainly situations where we do think about a total pancreatectomy. So if you think about what a normal pancreas looks like, a normal pancreas has the bile duct going through it, and it has this nice, very thin duct that goes through, and it's got side branches where all the enzymes come down. It's kind of like a leaf. If you have an IPMN, so many people end up with surgery because they have an IPMN that's growing and starting to look worrisome. And as it starts to, the edge thickens up or there's a nodule or something like that, and we become worried that a cancer is brewing or a cancer is growing. And so if you had an IPMN situation where you had an IPMN that's here, that's growing, and maybe there's a nodule in it, and that's a situation where you would do a Whipple as long as everything else looked okay. But if you have an IPMN where you have a nodule here, but then you've also got multiple IPMN going out to the tail, and maybe the duct is dilated and funny looking, this is a situation where you may consider a total pancreatectomy. So it depends on what it looks like, but certainly a total pancreatectomy is an option. Obviously, there's issues with that operation. Because as we said at the beginning, the pancreas does two important things. It makes insulin. So if you take out whole pancreas, your body is not making insulin. And so you have to supplement that through injections. And it also makes the enzymes that dissolve your food. So you have to take Creon or those pancreatic enzyme pills. So you can live without your pancreas completely removed. So it's certainly possible to live with a total pancreatectomy. It's more challenging though. It's It's much better if your body's making part of the insulin and then we're supplementing it with the endocrinologist. If the endocrinologists are giving you all of your insulin, it's harder to manage it. It's much easier to manage it now than it was 15 years ago because you have a continuous glucose monitor. And so it's much, much easier to monitor your glucose and respond to that now than it was 15 years ago. So if your tail is atrophied, because if you have a mass right here blocking the duct, the tail sometimes will atrophy. So the tail will get smaller because it's blocked here. And so then you're going to have a decrease in the cells that are making your insulin. And if it's blocked, certainly none of those enzymes to absorb the food are going to come through. So you can put it together, put everything back together with an atrophied tail. But you know, when we look at the scans, you can see on the scans if it looks like the tail is healthy or atrophied. And so if it looks atrophied, we usually tell people probably we're going to end up with some difficulties with the insulin management afterwards. But sometimes we look at the scans and it looks like it's plenty, but it's just not functioning well enough. So that's one of those things you find out after surgery. You can't really predict that. What are good margins? Oh, that's a great question. So that's a really tough question. And it depends on whose definition you use. So there are two definitions for a negative margin. So one definition is, I'm gonna make my cancer bigger here. Is there a 1 millimeter? So one definition would be 1 millimeter between the cancer and the cut edge of the pancreas. And one definition would be that the cancer cells extend all the way to the edge of the pancreas. Obviously, we don't like either one of those because in either one of those situations, it means the cancer was close to the edge of what we took out surgically. And anytime the cancer is close to the edge, you worry that the cancer kind of has little cells floating around. So the closer it is to the edge, the higher the chance that there are little cells that microscopically have invaded out into the tissues. This is one of those things that chemotherapy is aimed at, is getting rid of the microscopic cells that may be floating around. A lot of times when it's a close margin, it's nothing that we can change as surgeons. It was just the fact that it was a really big, ugly tumor and it was going to be close regardless of what we did surgically. So a lot of times what a close margin means is it was just a big, nasty tumor. So when you look at the chance of it coming back, if it's a big, nasty tumor with a close margin, it's higher chance of it coming back. So like I said here, the operation that we do is really pretty similar regardless of where it sits in the pancreas. It's the same operation if it's a 1 centimeter lesion or a 3 centimeter lesion. So we don't really modify the operation. We don't have an ability to modify the operation too much. And it's a very standard operation regardless of where in the pancreas it sits. Most people ask me afterwards, did I see it? No, I didn't see it and I didn't want to see it because it's sitting right there in the center of the pancreas. And we take out this loop of duodenum around it, and that's really part of the margins. So we take all of this out. I don't look at it in the OR. I give it to the pathologist and they deal with it. All right. So that's the surgery, big surgery. So then what happens after surgery? And so after surgery, assuming all of this goes well and there's no fluid collection, a lot of the issues are related to the stomach. So the stomach sits right here in front of all this. I drew it up a little bit higher just so everything looks okay on the drawing, but it's really kind of right on top of the pancreas. So the stomach in many people works fine. And then in some people, you get either end of the spectrum. It either empties too fast or it empties too slowly. So sometimes after surgery, because of everything that's happened back here, the stomach gets very annoyed with us and it gives up for a number of days. Sometimes it's a number of weeks. And we call that delayed gastric emptying. And sometimes that's what will cause us to do a CT scan or a CAT scan after surgery. Because if the stomach isn't working, we do a scan to look to see if there's a fluid collection that's causing that. And sometimes there is a small fluid collection that causes the stomach to be irritated with us. Sometimes the stomach is just irritable and there's nothing wrong on the scans. The scans look perfect and the stomach is still not emptying. Fortunately, the stomach always bounces back, but sometimes it takes it a little bit longer. So some people will be in the hospital not able to eat for a week or two, and sometimes even 3 after the surgery. That is one of those situations where you end up with a tube down your nose and you end up with IV nutrition. So we can support people really well, but it's not fun to sit in the hospital for 2 weeks with a tube down your nose. And that's delayed gastric emptying. And sometimes there's nothing on the scans that looks abnormal. The stomach is just in a bad mood and it doesn't empty, and then the food sits there, and then people end up vomiting if we don't have a tube in their nose. The other side of the spectrum is dumping syndrome. So the other side of the stomach being irritated with us is it pushes everything out really quickly. So before the surgery, which now you can't see much of anything, there's this little valve here called a pylorus. And it keeps the food from going out of the stomach quickly. So most of the food sits in your stomach for several hours and the stomach kind of churns and a little bit goes out every few minutes. When we do this, you can see this is wide open. And so when you eat something, it can fly through your stomach and really fly into the small bowel. And when it goes into the small bowel too quickly, it's called dumping syndrome, literally because the stomach just dumps everything into the small bowel. And a few things can happen there. Sometimes what happens is it pushes a lot of sugary food into your small bowel, and then you get a sugar rush, and then your pancreas makes insulin, and then you get a sugar crash. And so that will cause people to feel shaky and sweaty and unwell right after they eat. The other thing that it can do is just cause kind of cramps and spasms, kind of like if you go swimming too soon after you eat, you get kind of the bowel cramps because too much went in there too fast and it just overloaded the system. So whether the stomach is emptying too fast or too slow, the solution's about the same. So the solution is to eat lots of small meals spread out across the course of the day and really focus on the type of nutrition that you're eating, especially if it's dumping syndrome. So if it's dumping syndrome, you really want to avoid the sugars because the sugars are what drives a lot of the cramps and the sweaty and the shaky after you eat. So for either one, we advise people lots of small meals across the course of the day, so 6 to 8 small meals. If you have dumping syndrome, one of the things to do is eat and then drink a few hours later, so you don't eat and then drink and wash everything through really quickly. So separate your foods and liquids, which is kind of a strange piece of advice until you think about what's causing the symptoms that you're having. So after surgery, how long does it take to feel back to normal? And the answer is, it depends. It depends on what happened in the hospital. If everything goes through smoothly and you're one of the 50% of the people that go through with no issues, it still takes about 4 weeks to start to feel back to normal. It's a big surgery. This is a lot for your body to heal. It takes a lot of energy. So it takes a lot of energy out of you, even if you sail through it really quite smoothly. So it takes about 4 weeks to start getting back up to the normal energy level. And about 4 to 6 weeks after surgery is about the time we start talking about chemotherapy. So let's talk about chemotherapy and when you're going to start chemotherapy. So just as you get on that upswing of starting to feel better, that's when the team is going to start talking about chemotherapy. Most people, when I talk to them about this in clinic, they're like, okay, yeah, great, let's sign up. But then when we come to the conversation about chemotherapy with the medical oncologist, then they're worried about that. I can assure you that after this surgery, chemotherapy is a walk in the park for most people. So most people, once they go through a big surgery like this, they're like, oh yeah, like chemo was so much easier. I like the medical oncologist so much better than I like my surgeons. Just because this is a huge surgery. Nano knife. Okay, so yeah. Okay, lots of questions. Okay, so Steve, what would determine a classic Whipple versus a pylorus preserving Whipple? Is there a preference to the surgeon and their specific training? So yes. So in Toronto, most people do not do pylorus preserving. I trained at Brown, and where I trained, we did pylorus preserving. And actually, the guy who trained me as a resident really loved pylorus preserving. So when I came here, as one of the few people who did pylorus preserving. I don't think it makes any difference, and I've actually stopped doing it. So I don't think it makes any difference long term. And I don't think it makes any difference in blood loss in the operating room. It does make a little bit of difference in terms of delayed gastric emptying after surgery, according to the literature. But I stopped doing it because I don't think it changes anything. So in Toronto, you're not likely to get a pylorus preserving Whipple. I know there are other people who really, really, really deeply believe in it. But I don't know of any surgeons left in Toronto that do. Other places in the country, maybe. Concern about the main arteries? Yes, 100%. So this is just too messy for me to even look at anymore. So let's start with a new pancreas. So the small bowel, I drew it really short, is actually several feet. And as it goes down, it's got an artery. So there's a main artery that comes down here, and then it branches out and it fans out and it feeds the small bowel. So this artery comes off the aorta. So this is the SMA, the superior mesenteric artery. Similarly, the blood coming back from the small bowel, it goes up through the vein. And the vein actually goes into the liver. So it turns into the portal vein and it goes into the liver. So you've got a vein and you've got an artery back here. So if you end up with your cancer right here, it's not going to be touching the vein or the artery, but if it's a little bit further over, it can wrap around the vein and the artery. So if it's on the vein, we would just take a piece of the vein out. If it's on the artery, it gets a lot more complex. The vein is very elastic and very stretchy. So if you take 1 or 2 centimeters out of the vein, it's actually quite stretchy and you can put it back together nicely. If it's on the artery, it's more challenging to reconstruct it. So in Toronto, all of the arterial resections are going down to Toronto General, where they have everything for transplantation. So they have conduits that they can put in. So Ian McGilvery is doing all the arterial resections for the city. I think because of the complexity of this operation, that is the right thing to do. I know there are other places, I'm assuming that this would just be posted on YouTube. Yeah, if you're getting an arterial resection, I think you need to talk to the surgeon about the volume that they're doing. And that's why we put all of them in Toronto at Toronto General with Ian, so that he's running all of those cases, because there's a lot of special considerations for this. The vein resections, I think most high volume hepatobiliary surgeons are doing vein resections, so that's a little bit less of an issue. If it's sitting down here where it starts to branch, that becomes much more complex. And so you have to take each one of these cases case by case. This kind of rolls into the importance of being somewhere where people are doing a lot of this. And this answers the question of why do you have to repeat my films? So lots of people come to us from wherever because they came through an emergency department. And when you come through an emergency department, the emergency department doesn't quite know what's going on with you yet. That's why you're in the emergency department. And so they'll do a CT scan that's just a generalized CT scan. Just look, you've got abdominal pain. Maybe it's kidney stones. Maybe it's diverticulitis. Maybe it's appendicitis. So they do a very general CT scan. And if they find something in the pancreas, then we have to do a specialized CT scan. And the specialized CT scan is looking at this anatomy specifically. So it's another CT scan with the IV contrast, looking at the artery and the vein, making sure that both of those are clear, or if it's not clear, that it's something that can be resected. Now, if it's involving a significant amount of the vein, those are situations, or the artery, those are situations where a lot of times we think about chemotherapy first. sometimes to shrink it down, but quite often just to make sure that we have control of the cancer with the chemotherapy. So when it's involving the vessels, those are situations where we'll very specifically think about chemotherapy first. If it's completely resectable, I think it's a bit of a toss-up of whether you'd go straight to surgery or you do chemotherapy first. In fact, there are 2 trials in the world that are going on trying to answer that question, and we're involved in one of them, which is being led out of the United States to answer the question, is it better to do chemotherapy first or do the Whipple first? And there's a lot of reasons why chemotherapy first may be the right answer. If it's involving the vein or the artery, I think chemotherapy first certainly has merit. If you do chemotherapy first, you feel a little bit better, so it's a little bit easier. So if you're doing chemotherapy before the surgery, it's easier to tolerate the chemotherapy. And there's some data that would suggest that perhaps survival is a little bit better, but that's why we're doing the clinical trials, is to find out the answer to that. So that's the artery and the vein. Any other questions on the artery and the vein while we're on this one? Yeah, I know as a city, we've made, so in Toronto, we obviously have 4 HPV centers. So we have Sunnybrook, Trillium, St. Joe's, and Toronto General. And so the 4 of us have decided to just keep it at one place. For the rest of the province, I don't know. I like Westerns, it has in London has a transplant team. So they may be doing this separately. Yeah, so you'd have to talk to your team. So then nano knife instead of surgery. So we'll go back to this one. This is a big surgery. I didn't write down that this surgery takes about 5 to 6 hours if there's no vein involvement, if there's no pancreatitis, if there's no scarring, if there's no issues, and if the anatomy is normal. It's a lot of ifs. And so about 5 to 6 hours for the surgery. If everything looks perfect, it can be a lot longer if it's stuck to the vein or there's a lot of scarring from the stent or pancreatitis or something like that. So, we're talking about a 5 to 7 hour surgery. This isn't right for everyone, right? And sometimes radiation is a better option. So some people, who have a lot of problems, if you had heart problems, so if you were actively having chest pain, the surgeons and the anesthesia team would say that this is a terrible idea for you. So if you had heart issues and we didn't have control over that and didn't have an ability to quickly control that, radiation may be a better option for you. If you have a lot of frailty, if you're not able to get up and walk after a surgery, the most important thing for you to do is to get up and walk. But if you're coming into surgery, really frail, not able to get out of bed, maybe have lost a lot of weight because of the blockage and everything, a big surgery like this may not be the right thing for you. It may be that over time we could get you to a place where surgery is the right thing, but again, it's big surgery with lots of issues after surgery, so we want to pick who goes to surgery appropriately. So if someone comes in and they're quite frail and they're coming in with a walker or in a wheelchair, I can tell you this is a terrible idea, because this is just going to make you feel worse. And in that situation, radiation may be a good idea. There are some places that do nano knife. We tend to do SBRT or chemoradiation with our radiation oncology team here. And a lot of times when people come in, it becomes pretty obvious with discussions that they're not really keen to have this surgery, and I don't think it's a good idea for them. And so we'll get another scan and we'll get everything that we need in terms of the anatomy. And when they come back, they'll meet with me and the radiation oncology team, and we'll make a decision about what's right. Sometimes it's a big surgery, so it's not right for everybody. And I think, the magnitude of the surgery also answers the question of, why can't I have surgery if I'm stage 4? Well, if you have spots in your lungs, and I took out the stuff in the abdomen, we haven't fixed the problem. So if you have spots in your liver and I take out the pancreas, we haven't fixed the problem. We've taken out some of it, but if we leave spots in the liver, we leave spots in the lung or the bone or wherever they are, we haven't fixed the problem. And if we get to the situation where there is infection afterwards, you're not going to get on chemotherapy, and chemotherapy is really what you need. So that's why most people with pancreas cancer actually do not get surgery. Only about 10% of people with pancreas cancer get surgery. Most people, it's spread somewhere else. It's invading too much in this area. It's invading too much around the blood vessels, and surgery is not a good option for them. And that's, it's because of two things. Number one, pancreas cancer is horrible. And number two, it's a big surgery and it sets you back so far. So you have to have a situation where you can get control biologically and cure metastatic disease like colon cancer. Colon cancer, if you have a spot in the liver, you can have surgery on the colon, you can have surgery on the liver, and we can cure you. Why we can do that for colon cancer and not pancreatic cancer, I don't know. It's not fair, but that's how biology works. Just a few lesions in the liver. Yeah, so the problem with the idea of just a few lesions is this, and a cancer, I think of cancer kind of like cockroaches. So if you walked into your kitchen and you saw a cockroach in your kitchen and you stepped on the cockroach and killed it, you would never think, well, there, I fixed that problem. There's nothing else going on. So if you walk into your kitchen and there's a cockroach and you step on it and kill it, the next thing you're going to do is go out to Canadian Tire or Home Depot and get Raid or call the pest control people, because you know that there's more there. And that's cancer, right? So if we see one spot in the liver, the spot that we see in the liver with the scans has to be a certain size. The spot that we see has to be the best MRI, the best radiology, the best of best is 2 millimeters, maybe 3 millimeters. So, that's a fair amount of cancer cells. That's millions and millions and probably billions and billions of cancer cells to get to 2 or 3 millimeters for us to see. And certainly, without like the best quality MRI, it's going to be about 6 to 8 millimeters before you can see it on the scans. So again, that's billions of cancer cells. So knowing what we know about pancreas cancer and how awful it is and how easily it spreads, you have to assume in your mind that there are other cancer cells somewhere else. So the cancer cells are somewhere else in the liver, they're somewhere else in the blood, they're somewhere else in the lymph nodes, they're somewhere else in the lungs. And is that a nihilistic way to live? Yes, but you have to have respect for pancreas cancer and how sneaky it is. So that's why chemotherapy is really the mainstay of treatment for pancreas cancer, because we know that it spreads through the blood, and we know that it hides, and we also know that it has to be a certain size before we see it. And so there's probably something else. So are there situations where with a very limited amount of disease in the liver, surgery's been done? Usually not. So usually we don't embark upon a Whipple if we know that there's liver metastases. Certainly there's situations where we've done a Whipple and then years later, one thing pops up. Would we radiate that or burn it? Maybe depends. I mean, I think in those situations, we have a very long conversation. We have a conversation at our tumor board where we have the radiologist, we have the pathologist, we have the radiation doctors, we have the interventional radiologist, we have the surgeons, and we have the medical oncologist. So we have everyone sit down every week and go through all of these cases. And it would be a very special case where we would treat that. Most of the time when you see a liver metastasis, you assume that there's something else going on, and the answer is chemotherapy. Again, histiotripsy, the kind of new kid on the block. We use more conventional and more researched things like microwave ablation or SBRT. So is it an option? Yes, it's got the same problems though. So radiation, microwave ablation, surgery, histiotripsy, all of those are the same thing. They're focused on this. I'm a liver surgeon. I can very easily cut that out, but I would never do that because it's not going to fix the systemic problem. But surgery and burning and radiating and histiotripsy, all of that's just going to focus on this one area, whether it's a metastasis or a lesion in the pancreas. And that's why chemotherapy is important, because it goes everywhere, and it's more like fumigating your house than just stepping on your cockroach. Yeah, no, doing the Whipple doesn't stop it from spreading more, because it's a horses out of the barn situation in many cases. So we know from research where they take circulating tumor cells, we know that the cancer is circulating in the blood in many of these patients. We would never think, I'm just gonna do surgery and that's gonna fix everything. So that's why we always are talking about surgery and chemo. And so really the question is not, do we add chemo to surgery? The real question is, when do we add chemo to surgery? Do we add it before or do we add it afterwards? We don't do nanoknife here. So there's a bunch of other things. There's histiotripsy, there's high frequency ultrasound, there's nanoknife, there's cryosurgery. There's a whole bunch of things that are advertised. Histiotripsy, basically, they are focusing energy on this area to break up the cellular matrix of the cancer cells. Nanoknife, same thing. So they're trying to break up the cellular matrix on the cancer cells so that the cancer cells explode. The advantage of those and the advantage of the radiation is that you don't have the surgery, so you don't have this whole recon and these adverse event rates. But the histotripsy and the nanoknife, I would say, don't have as much data as surgery, obviously, or radiofrequency ablation or radiation to this area. But if you do radiation to this area or you do histiotripsy to this area, you're only treating this one localized area. You're not taking out all those lymph nodes. And so when people sit down and talk with the radiation oncologist are going to tell them radiation to this area is not likely to cure this cancer. Right, so radiation will slow it down. And in many situations, you'll have a case where it's going to be 12 to 18 months before it comes back. But the radiation oncologists are never going to sell this as a curative option. The only thing that we know that will cure the cancer is surgery. But for the surgery, even with surgery combined with chemotherapy, the chance of curing a pancreas cancer is low. And so in the best case scenario, with no lymph nodes and a small tumor, the chance of cure is somewhere in the 40 to 60% range. So even for a T1 N0 with chemo, there's still quite a decent chance the cancer is going to come back. So surgery is the only thing that we know that will cure it. Radiation, we do not claim that radiation is going to cure it. The radiation is to kind of control it and keep it from growing. But the histotripsy, high frequency ultrasound, nanoknife, radiation, all of those they're not going to be advertised as something that cures the cancer. However, we got to be realistic about it. They also don't have the side effects of surgery. So if you're more frail, those may be really good options for you. Questions not answered. Which questions were about the nanoknife? Or about something else?
I'm just scrolling here to see. Oh, is surgery performed because of what is seen on the CT scan before the pathologist actually confirms that it is pancreas cancer? Would a neuroendocrine tumor be treated differently than a carcinoma? How do you know the difference between pathology tests are seen?
Okay, sorry, I didn't see that one.
Mhm.
Oh, we missed a few. We didn't, we missed the drain question too. Okay, we might miss a lot. All right.
Sorry,
Um,
Dr. Cooper, you're coming in so quick.
sorry, yeah, they came in really fast. You want to scroll back and make sure we didn't miss anything else?
Sure.
So I'm gonna answer the drain one because that one's easy. So the drain, again, there's this chance of having a fluid collection. So I think the drains here at Sunnybrook, I think it depends. A lot of this is it depends. If the surgery went really well, and if the pancreas was a reasonable quality, and if the duct was reasonable, and if there was no vein resection, then we would not leave a drain. But if we do a vein resection, we all leave a drain. If you get to this situation, I drew this duct really nice and big. If you get to this point and you divide the pancreas and the duct is 1 millimeter and the pancreas is really soft and fatty, we know that those are situations where it's more likely to have this fluid collection. So we would usually leave a drain there. So it depends on what the surgeon sees at the time of surgery. So sometimes yes, sometimes no. If there's, if there's a lot of concerns, yeah, I might leave 2 drains. It depends on what everything looked like. Is a surgery performed based on what we see at the CT scan? A lot of the time. So unlike the medical oncologist and the radiation doctors, at the end of all of this, I do have a surgical specimen, and I do have the tissue that can go to pathology, and then the chemotherapy doctors can make decisions about it. If you just radiate it, you don't have that pathology. So in general, before radiating, the radiation oncologist would require a biopsy in order to do the radiation. So usually we'll do an endoscopic ultrasound. So it goes down through the stomach and then they'll biopsy the lesion in the head of the pancreas. There are situations where we do an endoscopic ultrasound biopsy and it's not diagnostic, right? It's a tiny, tiny amount of cells. It's just a tiny little biopsy that we give to the pathologist. And sometimes the pathologist looks at it and they can't say what it is. And so if we're looking at radiation or chemotherapy up front, sometimes we'll repeat it. And sometimes it's still non-diagnostic. And this is where having a really good tumor board and a really good radiologist is really important. I trust my radiologist with so much because they're really good. And they'll look at the films and they'll say, I know the biopsy is negative, but that's a cancer. I think most of the hepatobiliary centers in Ontario, there are very good radiology teams because they see so much of it. So this is why you want to go to a high volume center. You want to go somewhere where they're seeing a lot of it. And so in Ontario, I don't know if everybody's from Ontario, but in Ontario, hepatobiliary surgery is regionalized. And so it's in 11 centers and that's it. And that's so, it's for the surgeons, but it's for everything else. It's for the chemotherapy doctors, radiation doctors, the radiologist, the ICU, the ability to place drains safely, the anesthesia team. Everyone sees a lot of pancreas surgery at one of these HPD surgery centers. And one of the key things I do think is the radiologist. If my radiologist looks at a spot and they say, that's a cancer, even if the biopsy is negative, then we would go to surgery because they see so much of it. If they're almost always right. The chance of them being wrong is every once in a while they're not correct, but it is really low. So if they're worried that this is a cancer, I would take it out without a biopsy. Now, the chemotherapy doctors don't have that same ability because they have to have the pathology to know that there's a cancer there before they start you on chemo. Same with the radiation oncologist. There are things that look different between a pancreas adenocarcinoma and a neuroendocrine tumor. And so based on what it looks like on the scans, the radiologist will say, I favor a neuroendocrine tumor or I favor an adenocarcinoma. And so that's another situation where we would put a needle into it and biopsy it and have the pathologist tell us what's correct. Neuroendocrine tumors are a completely different animal. They behave so differently than pancreatic adenocarcinoma. It's a completely different talk altogether. And a lot of them are very, very, very slow growing and very, very, very benign and don't do anything. And so if you have a 1 centimeter neuroendocrine tumor in the head or the tail of the pancreas, a lot of times we're just going to tell you, let's just watch that, because who wants to go through this giant surgery for something that was never going to grow, never going to change, and never going to hurt you? And that would be for a tiny, well-differentiated neuroendocrine tumor. A lot of those we just watch. So you don't know the difference before pathology. You can guess it, but if you're going to be watching something in the pancreas, you want to biopsy on it for sure. Margin.
I thought, yeah. Mary said, is the center the same as the neck of the pancreas?
Yeah, the center would be the neck. Yes. Yeah.
Ben said losing 6 units of blood, is that normal?
That's high blood loss. It depends on what it was stuck to, though. If it's stuck to the vein and the artery, that can certainly happen. You know, the amount of blood that flows through the liver is about 1 liter a minute. So this vein carries a tremendous amount of blood. And so if the tumor is stuck to that vein, you can certainly lose a tremendous amount of blood very quickly, because it's carrying all the blood that's coming back from the small bowel, circulates through the liver, gets filtered, and then returns to the heart. So major conduit for blood in the body, and it's about 1 liter a minute that goes through that area. So it can't, ideally not, but certainly that can happen, yeah.
And then Gary said, do you do genetic testing on the removed pancreas and use it for research?
Yes, they do genetic testing on it. They'll probably do MSI testing on all of these patients, especially younger patients. There is not as much known about pancreas cancer as we know about breast cancer or colon cancer. It's a harder one to research, and it's really, even for dedicated researchers, it's been a little bit more of a harder nut to crack. So if you have a breast cancer or a colon cancer, there's this whole series of mutations. You can go, you know, if you're on this mutation, you take this drug, and if you have that mutation, you take that drug. Pancreas cancer is not so nuanced because we don't have a lot of ability to tailor the therapies for patients. There's certainly researchers who are working on that. The tissue that we take out does not routinely go for research, though. It would have to be something that you would consent to, and if your program has a research situation and has a trial, they would talk to you about it. The tissue doesn't automatically just flow to research. You have to consent to that. There was another one I saw up top.
Yeah, Ben had just said vein on liver on opposite side. He was talking about the blood loss, I think.
Yeah, that could certainly do it for you. So the question of the guidelines for chemo. Again, it depends. There's a lot of it depends. And so because there's a lot of it depends, this is really someplace, you know, you want the chemotherapy doctor and the surgery team to be sitting together in the clinics and making these decisions, or sitting together in tumor board and looking at the films with radiology every week. So right now, standard of care, if it's resectable, standard of care would be to go to surgery first and then do chemotherapy second. In the United States, I think many centers have moved towards doing chemo and then doing surgery. That's without a significant amount of evidence within the worldwide literature. So it's something where it seems like it's the right thing to do. But the randomized controlled trials haven't really been fully conducted to support doing that. But it is something where in the US they have moved towards that. It does seem like it to all of us, and that's why we're involved in those trials. Because the only way you can know the answer to that is to do one of those trials where it's a flip of a coin, and you've got a 50% chance of going to surgery, and you got a 50% chance of doing chemotherapy first. And that's how we answer those questions. And so that's why being involved in clinical trials is really critical for us to understand what's the best therapy. And also people who are involved in clinical trials usually tend to do a little bit better on average than people not involved in clinical trials, because if you're in a clinical trial, you've got more eyes on you. So there are more people watching you. You've got a nurse coordinator, you've got a CRA or a clinical research associate watching you. Everything is watched in a bit of a different way. So clinical trials are really important for us to understand what to do, but also better for you probably. How many, so the answer is it depends. So around the time of surgery, usually we're looking at 6 months of chemotherapy. And usually the medical oncology team is going to give the chemotherapy every other week. So they're going to do 12 cycles after surgery, and that usually is 6 months, but it depends on how you feel. If you are not feeling very well on chemotherapy at all, and you started out with a really small cancer, they may say on balance, you're miserable on chemo, let's cut it short. If you're on 2 years, I would assume that this is a locally advanced situation or a metastatic situation. So it's going to be a balance. It's how is the cancer responding? Do you have it under control? And how do you feel on chemotherapy? Are your symptoms under good control? And if you're feeling okay on chemo, and many people with pancreas cancer actually feel okay on chemo. It's different than breast cancer chemo or leukemia chemo. It's an easier chemotherapy to tolerate. The side effects are not as bad. So if you're feeling okay on chemotherapy and the cancer is under control, then probably continuing the chemo is the best thing. But those are things, that's why you see the medical oncologist every cycle or every 2 cycles, because they're constantly reevaluating, what happens next, what happens 2 weeks from now, how are the symptoms managed, what's the CA19-9, what do the scans look like, how do we strike that balance? Usually, like lungs only is not usual. Usually you'll have it's liver and in the abdomen and the peritoneal surface, like carcinomatosis, and then lungs and bone is also unusual. But we know pancreas cancer can go anywhere. Brain is very unusual, but it can go to lungs alone. Like most of the time we see it in the liver, or just really in a lot of the lymph nodes in the area that makes it, like I said, 90% of people who come through the system with pancreas cancer don't go to surgery. Sorry. Clearly in the hospital. So in terms of things that sit in the pancreas, a pancreas adenocarcinoma, a neuroendocrine tumor, those look a little bit different on the scans. A kidney cancer, for whatever strange reason, sometimes a kidney cancer will spread to the pancreas. It's an odd place to metastasize to, but sometimes a kidney cancer will metastasize to the pancreas. You can have, so one of the things that's hardest for the radiologist to sort out, sometimes you can have pancreatitis that will kind of coalesce into a little bit of a ball. And so you can have pancreatitis from before, a year or 2 years, 10 years before, and now you get a scan and it'll show something that looks like a mass or a spot on the pancreas, and then you take it out and give it to the pathologist and they'll say that was pancreatitis. So there are things that are benign that can show up in the pancreas that aren't cancer. It doesn't happen often, but when you're doing 100 Whipples a year, 1 or 2 throughout the year will come back as benign pathology. But again, if my radiologist says I am worried about that, it doesn't matter if what the biopsy shows, because the sampling for the biopsy is so small, the chance of it missing something is very, very high. So if my if my radiologist says, I'm worried about that, then, you know, we really kind of have to take it out. Because the chance of it being a pancreas cancer is overwhelmingly high. So renal cell carcinoma would be the main thing that would go spread to the pancreas. That's not arising from the pancreas, and then neuroendocrine tumors will arise in the pancreas. So that's okay. So that's slightly different. So that's going to be in the bile duct. So sometimes you can have a blockage here, and you don't know if it's a cholangiocarcinoma pushing out into the pancreas or a pancreas cancer pushing in. So a cholangiocarcinoma that's sitting right here in this distal part of the bile duct certainly can cause the same problem as a pancreas cancer. It will, sometimes a radiologist will say it's a cholangiocarcinoma. So, you know, a lot of times they can tell it's in the bile duct. Sometimes they can't, and again, the pathologists say it. Most of the time, it's a duodenal cancer. So a duodenal cancer, if it sits perfectly right here, might push into the pancreas and look a little bit more like a pancreas cancer. But if you looked down endoscopically, you would see it. So you would be able to sort that one out pretty well. A specifically situated cholangio, yes, would be yeah. As far as surgeons go, you treat all of these the same. So whether it's a duodenal cancer pushing in, or a cholangiocarcinoma pushing out, or a pancreas cancer pushing in, it's the same surgery. You don't change your surgery at all. Sorry, I thought you guys were just talking about the pancreas part of it. IPMNs. IPMNs are very complex because you have to look at each one individually. It depends on the size and really what it looks like and the complexity of it and how fast it's growing. And you know, is there anything else, anything genetic in the family? Are there nodules? Is there thickening? Does it enhance on the MRIs? So if there is an IPMN that is behaving badly, then yeah, an EUS biopsy I think is definitely something that's very important. If there is an IPMN that really looks like it is transformed into a cancer, then same thing, if the radiologist says, I'm worried that there's a cancer there, we would take that out. Now, sometimes you take out a nasty looking IPMN and there's no cancer in it on the day of surgery, but if it's an IPMN that's growing and there's a nodule and there's thickening, these are certainly situations where we worry over the next year or few years it would have turned into a cancer. So it's a bit of a preemptive Whipple. But if there's nodules in it, then that's probably the best option for most people. Is there any reason to replace a stent that was put in the bile duct? I think it depends on if it's a plastic stent or a metal stent. So plastic stents, I tell my patients, invariably get clogged. They're really thin. They're kind of like the inside of an old Bic ink pen. They're super thin, so it doesn't take much to clog that. The metal stents have a diameter of about 8 millimeters, so they're much bigger. They're less likely to get clogged. So plastic stents, most plastic stents will make it about 4 to 6 months before they cause trouble. Plastic stents are very easy to change and exchange in and out. Once you put a metal stent in, you're kind of stuck with it because you get it grows into the wall of the bile duct. So many metal stents you cannot remove. There's reasons to do the plastic and reasons to do the metal. But if you have a plastic, almost all of them will end up causing some problems around the 6-month mark. So anything that blocks the bile duct will cause, so the question, I'm going to read it because for the video. So the question is, when a stent starts to clog, is it common for the CA19-9 to rise? Yes. So anything that blocks the bile duct, a stone, a cancer, a stent can cause the CA19-9 to go up. So if you have a bilirubin of 200 because of a cancer, the CA19-9 on that day doesn't really count. Because the CA19-9 will go up with the stent clogging it or with a cancer blocking it. So a CA 19-9 only really counts when you have a normal bilirubin. So the good thing about chest CTs these days is they're really good at picking up very, very small things. The bad thing about chest CTs is they're really good at picking up very, very small things. So if you did a chest CT scan on everybody who's on this call, some number of us, probably around 10%, maybe even 20%, you would see these small little thingies in our lungs. Maybe you had a cold last month, maybe you had a pneumonia when you were 8 years old and it's scarring. And when you have these little things in the lungs, like 2 millimeters, 1 millimeter, it is impossible to know what it is. So small, sometimes the radiologist cannot definitively say. The radiologist can look at the scan and say, I'm worried about what's going on within the chest. But you know, in the kind of the 2, 3, 4 millimeter range, they can't really say it definitively. Now, if you have something that's 4 millimeters and in 2 months it's 6 millimeters and in 2 months it's 8 millimeters, almost invariably. But if you have something that's 4 millimeters and then 4 millimeters and then 4 millimeters, it's hard to know. And you had something that was 6 millimeters and you went on chemotherapy and it shrank to 2 millimeters, that starts to become worrisome for cancer as well. But it could also have been in, you know, that cold you had in December and it was just getting better and it would have gotten better anyhow. So the lung spots are challenging, and a lot of times the only way lung spots get sorted out is over time. And if you read the radiology report, the only thing the radiologist can say is there are X number of spots, here's the sizes, and I'm worried about it or I'm not worried about it. Unless you have a series of scans over time and they can say it's growing, therefore it's a cancer. If it's something, you know, if it's 2 centimeters, it becomes easier for the radiologist to be definitive. But if it's this scattering of really small spots, that's a hard thing for the radiologist to call. And so the same thing, our radiology department is very, very, very specialized. So the folks who read the chest CT are different than the folks who read the abdominal CT. And that's a different part of radiology than the mammogram. And it's a completely different part of radiology than the brain radiologist. So they're all very, very specialized, and so the chest radiologists just look at the chest. They just look at the lungs and the heart. And they'll say, I can't tell. I can't say definitively. And the reason they make those statements is because it really matters. Because if they said definitively 100% this is a cancer, that changes what the medical oncologist is going to do and what they're going to tell you. So if they are stuck in that middle zone, it's because they know that the weight of their words is so important. They don't want to say things that would make a treatment decision happen if they're not sure. So I know it's frustrating when they hedge, but there's a
that was great. I see lots of people saying great presentation, best presentation ever. Thanks, Dr. Coburn, excellent presentation. So lots of people really, really enjoyed it. And we really appreciate you and your time today, Dr. Coburn. Thank you so much.
Thank you. And thank you for doing all of this, because there's what we can do here in the cancer centers and within the healthcare system. But there's a job with education and with support outside the cancer system. Because, you know, there's questions you ask in this forum that you don't really ask in the clinics. And so it's necessary to have both of them. So thank you.
Totally. Oh, thank you so much. Yeah, we're so grateful, and we're grateful to be able to help patients, you know, that you're helping so much, and we're happy to just have any part in it. So thank you so much. Thank you everyone so much for taking the time on the weekend to come to the presentation. Oh, sorry, Dr. Coburn.
Everyone's gonna have a nice long weekend now.
Yes, yeah, exactly. Everyone gets to go and enjoy. So thank you so much, everyone. Enjoy the weekend. If anyone has any questions that you want me to send on to Dr. Coburn, you can email them to me at erin@craigscause.ca. Otherwise, hope everyone enjoys the weekend, and thank you so much again, everyone, for your time. And thank you, Dr. Coburn.
Great, thank you. Thanks, guys.
Yeah.